Hey everyone, welcome to our NCLEX RN review session on bariatric surgery unfolding case study. In this session, we'll work through 6 NGN test items, and each targeting essential cognitive skills to help you excel on your exam. And today, aim to test your knowledge by completing the entire practice test and share your score in the comments below. Let's get started. So here's our case about a 34-year-old male who presented to a bariatric clinic to discuss weight loss options, reporting lifelong obesity, increasing fatigue, and difficulty managing blood pressure despite medication. He is frustrated about a 15-pound weight gain over the past year. It says here, the nurse conducts a thorough assessment reviewing clinical data to identify findings requiring immediate follow-up as the patient is evaluated for Roux-en-Y gastric bypass surgery. Highlight the findings in the provided tables that require immediate nurse follow-up. And here are the tables. That's just one of them. There's another, and that's the third one. So let's go through each of these tables. It says in the history and physical, this patient has metabolic syndrome, type 2 diabetes mellitus, hypertension, obstructive sleep apnea managed with CPAP, and has prescriptions to take metformin 500 milligrams twice a day, lisinopril 10 milligrams daily, atorvastatin 20 milligrams daily, ibuprofen occasionally taken for joint pain, and denies smoking or alcohol use. His current weight is 325 pounds. That's 147.7 kilos. A BMI of 49.2. Frustrated about 15-pound weight gain. And his current vital signs, we got blood pressure of 180/94, heart rate 88, respiration 16, temperature 98.6, and oxygen saturation of 95. He stands 5 feet and inches tall, and his waist circumference of 45 inches, waist to hip ratio 1:1. And cardiovascular assessments here. He has regular rhythm, no murmurs, shortness of breath on exertion, snoring at night. He is alert oriented ×3, reflexes 3+ overall, has trace edema in ankles, bilateral knee pain, and daytime sleepiness, uses CPAP nightly. Now let's go over into the diagnostic tests. We have ECG showing normal sinus rhythm, no ischemic changes, chest x-ray showing normal heart size, no infiltrates, and the sleep study showed apnea-hypopnea index of 30, which is consistent with severe obstructive sleep apnea. And for his echocardiogram result, he has a left ventricular ejection fraction of 58%. That's normal, with mild left ventricular hypertrophy. Now let's head into the laboratory results. Blood glucose of 195 milligrams per deciliter, hemoglobin A1C 8.4%. The high-density lipoprotein of 32 milligrams per deciliter, low-density lipoprotein of 160 milligrams per deciliter, total cholesterol 280 milligrams per deciliter, triglycerides 190 milligrams per deciliter, hemoglobin of 11.5 grams per deciliter, hematocrit of 36%, BUN 17 milligrams per deciliter, and creatinine of 1.0 milligrams per deciliter. So you can pause this video and organize your thoughts. Make sure that you scan each row so you're not going to miss any of the significant findings here. And when you're through, you can proceed so that we can start answering this test question. Now, before we're going to highlight these findings, I just want to emphasize here that the criteria that you should follow through would be for those findings that are acute, those findings that can pose higher risk of life-threatening complication. And so if the patient has something serious going on, then that needs immediate nursing action. So these are the red flags, findings that you would escalate, something that you would treat or report right away to the healthcare provider. Now, another criterion that you should consider before you highlight are those findings that affect the surgical readiness or will increase the peri-operative risk of this patient. So I'm talking about anything that could interfere with the patient's safety before, during, or after the surgery, like poorly controlled diabetes or untreated sleep apnea. Those need to be addressed. And so these findings might delay the procedure until the patient is stable. Another criterion that you should keep in mind for those findings, make sure that you are going to capture those assessment findings and that you can intervene within your scope of practice, and that requires immediate action. So if that is something within the scope, like let's say administering a medication, or let's say, or any of those assessment findings that would require you to possibly administer a standing order, like a medication, or maybe that would cause you to monitor this patient, or maybe cause you to teach this patient now, or maybe to make that referral, then that is also a priority. Another criterion that you should keep in mind is to identify those findings that are critical or those that are significantly abnormal. Those lab values that are well outside the normal range that can point to serious underlying problems. So these findings often require urgent follow-up or more tests to prevent the condition from worsening. Another criterion that you should keep in mind are for those manifestations that suggest the patient is at risk for decompensation. So I'm pertaining to those manifestations such as shortness of breath, affecting their ABCs, maybe dizziness or chest discomfort. It could mean that the patient is deteriorating. So you got to catch those findings, because early recognition and early intervention are key to avoiding those crises from occurring. So let's get started. One of those findings that you should highlight here should be this one. Weight 325 pounds. Or 147.7 kilograms, because this weight places the client in the severely obese category that's well above the 300-pound mark. This can qualify someone for bariatric surgery when other conditions like diabetes or hypertension are present. And for you as a nurse working for this virtual patient, that means that you need to assess for weight-related symptoms such as shortness of breath or maybe joint pain. And you also need to help connect the patient with specialists like bariatric surgeons, dietitians, and also to educate them on weight loss, not just for surgery eligibility, but also to lower the risk of serious issues like heart disease and diabetes. So that's very important. Another aspect that you should highlight is the BMI of 49.2. So this reflects class 3 morbid obesity, which significantly can raise the patient's at risk for things like heart disease, diabetes, and joint damage. That's a lot of weight to handle for the knee joints. And from a nursing perspective, this BMI supports eligibility for bariatric surgery. So our next step is to include assessing for related conditions, making referrals, and to begin education on reducing modifiable risk factors. Another thing that you should highlight is blood pressure of 180/94. This is a case of stage 2 hypertension, which is very serious. It greatly increases the risk of stroke and heart attack. So your priority here is to recheck the blood pressure, inform the care provider. They may increase the dose of her medications or his medication, and also to educate the patient on dietary changes like reducing their intake of sodium or salt and probably increasing a little bit of their exercise. And this is not something we just monitor, we act on it immediately. Another finding that you should highlight is this one: shortness of breath on exertion. So when a patient gets winded easily, especially with obesity and hypertension, we are going to worry about their cardiac strain or maybe respiratory compromise. And it's very important for us to assess their respiratory function and to check if they are stable enough for surgery. And with that, we're going to alert the provider right away, especially if the symptoms worsen, because it might delay surgery or it indicate an urgent cardiac pulmonary issue. So what else do we need to highlight? We have snoring at night. Loud snoring is a red flag for obstructive sleep apnea, which is a condition that can cause nighttime oxygen drops and heart problems. So we need to check whether the patient is using their CPAP regularly, or maybe they just turn it off once they wake up in the middle of the night and just they try to sleep without wearing that machine or mask. So this patient needs to be referred to a sleep specialist if needed. And we are going to educate on how untreated obstructive sleep apnea can affect their surgical safety and for their long-term health. Another is daytime sleepiness. When they feel overly tired during the day, it's a symptom of severe obstructive sleep apnea, especially if the sleep study shows an apnea-hypopnea index of 30. Go back into the test table. That's 30. So that's reflecting severe obstructive sleep apnea. So this is not just uncomfortable, it's dangerous. So think about falling asleep while they are driving. So we need to encourage consistent CPAP use and make sure a sleep specialist is involved in the care plan. Another finding that you should highlight is this: trace edema in ankles, because this could be from venous insufficiency or high blood pressure, commonly in people with obesity. Even though it's not that urgent, we want to keep an eye on it because it could worsen or hint at heart failure or maybe presence of blood clots. And that's why you have to follow up on this one. You have to monitor closely, assess the patient circulation in those extremities, and report as needed. Another is bilateral knee pain. This is likely from the obesity-related osteoarthritis. So this is going to make them so difficult to be mobile. So this is going to reinforce the need for bariatric surgery. And you, as the nurse in this case, you should assess the pain. You have to teach joint protective strategies, and also coordinate with the providers for pain control and mobility aids. All right. Next is apnea-hypopnea index of 30. That's in the sleep study. And so this confirms the OSA diagnosis. It means the patient stops breathing many times an hour during sleep. This is very risky, especially around surgery, when anesthesia and sedation can worsen their breathing. And you, as a nurse in this case, you should ensure that CPAP is being used, and you have to follow up with the sleep team, and you need to educate the patient about the life-threatening risk of untreated obstructive sleep apnea. Next, pay attention to this one: blood glucose of 195 milligrams per deciliter. This is elevated. It means the patient's blood sugar is uncontrolled. This is bad news for the wound healing and bad news for infection risk. So we are going to report this right away to the healthcare provider, and possibly this patient may need to start insulin injections. So we need to educate on how to monitor glucose levels and to avoid those complications. Another is hemoglobin A1C of 8.4%. This gives you an idea how long-term their glucose is not controlled. 8.4% is too high. So it tells us that the patient's diabetes has not been well managed. Maybe he's taking the medication, but maybe he's not controlling the diet aspect, or maybe both. And so you have to reinforce education about adherence to taking their medications, adherence to the diet regimen, and make sure that they are monitoring their blood sugar at home, and also to make sure that they do follow up because that is a must to reduce long-term complications of diabetes. Let's look into the next one. We have hemoglobin of 11.5. This is quite low for a male patient because this one can make them feel exhausted, and the low hemoglobin is also a surgical risk. So we are going to evaluate the patient for symptoms like fatigue, shortness of breath, and follow up whether iron supplementation or maybe further workup is needed for him. Another here is hematocrit of 36%. This is a reflection of their anemia, which affects the oxygen carrying capacity. Again, it's not just about the number. It's about how the patient feels and what risks poses in surgery. So we are going to ensure the treatment is in place and support dietary education for iron-rich foods. Another assessment finding is this one: high density lipoprotein of 32. This is supposedly the good cholesterol, but this is too low. That means the patient has a higher risk of heart disease. And you as a nurse in this situation, you play a big role in education. So you're going to encourage physical activity, intake of healthy fats, and making sure medications like statins are being taken properly as prescribed. Another here is the low density lipoprotein of 160 milligrams per deciliter. This is the bad cholesterol that is too high. So you need to address this to prevent heart attacks and strokes. So you as a nurse should reinforce compliance to taking their medications, possibly statins, to teach them about dietary changes, consumption of less saturated fat, and make sure that you monitor the patient for the side effects as well. Another is total cholesterol of 280 milligrams per deciliter. This is another strong sign of uncontrolled lipid levels. So this value also adds to the cardiovascular risk, and it needs to be a multi-pronged approach. So you're going to address for the patient's lifestyle change, medication compliance, and follow up for their lab values. We also need to highlight this one: triglycerides of 190 milligrams per deciliter, because this is linked to metabolic syndrome and increase the risk of pancreatitis and cardiovascular events. So this needs immediate lifestyle counseling and perhaps medication changes as well. And you as a nurse can provide effective teaching and support this time. So let's talk about the remainder of the findings here that we are not going to highlight. So an example is that statement where he says, frustrated about 15-pound weight gain. That's in the H&P, in the general category. So this shows that he is experiencing emotional distress, but it is not an urgent clinical finding. We still assess that because mental health is something that you should address routinely, but this doesn't need an emergency referral. It's something that we can address with empathy, but not prioritize medically over more serious findings. So keep that in mind. Of course, we have the height of 5 feet 8 inches. That's just a number part of the BMI calculation, but on its own, height doesn't pose any clinical risk. And the waist circumference, 45 inches. This shows central obesity, which is important, but it doesn't add anything new beyond the weight and the BMI that we already identified. So this is something that we can use for a long-term risk assessment, but not for urgent decisions. So it's not prioritized for immediate follow-up right now. No. Another is waist to hip ratio, 1:1. Again, this ratio points to the abdominal fat distribution, but this one is less impactful than the BMI and actual weight that we already highlighted. So this one is something that we can use for population studies or long-term tracking, but it doesn't drive immediate care plans for nursing actions. All right, let's talk about the vital signs here. Heart rate of 88 beats per minute. It's within the normal range. It doesn't signal any acute issue. It doesn't change the patient care plan. For the respirations, that also normal. Same thing with the temperature, oxygen saturation. So I'm not going to elaborate on those. In the cardiovascular, it shows regular rhythm, no murmurs. Well, that's a good thing, right? As far as neurological, his alert oriented ×3 reflexes 3+. That's good. And uses CPAP nightly. Well, that is a subjective report. That's a good thing. If he says that he is using it nightly, it's a treatment, it's not a problem. So the issue is whether symptoms like sleepiness are still present despite using the CPAP, but not the use of CPAP. It's not a problem there. Another is the ECG, normal sinus rhythm, no ischemia. Well, that's good, right? And for the chest x-ray, no infiltrates, normal heart size. And the echocardiogram showing left ventricular ejection fraction of 58%. That's a good thing, right? So his heart is pumping normally, and there's some mild thickening of the heart wall that is expected with a person who has high blood pressure. Chronic blood pressure, hypertension, I should say. So this is something that you can monitor for long term, but not that you can act on right away. All right. We have a BUN of 17. That's within a normal range. We just continue routine monitoring unless other symptoms arise. Same thing with a creatinine of 1.0. That's perfect. It indicates normal kidney function. So it does not meet any of the criteria that I mentioned. Or criteria. All right, let's move forward here. You're good if you have highlighted all those assessment findings, but I'm just going to show you the subsequent healthcare provider orders that were finalized after the visit. So it says here, refer to a bariatric surgeon for Roux-en-Y gastric bypass evaluation, nutrition consult for low-calorie, high-protein pre-surgical diet, metformin increased to 1,000 milligrams twice a day. Add insulin glargine 12 units nightly. Lisinopril increased to 20 milligrams daily. Iron supplement 325 milligrams daily for anemia. And sleep specialist referral for CPAP optimization. All right, let's proceed to our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions. Practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It says, based on the initial visit data, the nurse analyzes the patient's risk profile. So feel free to review the records. I'm not going to read them one more time. So you can pause the video and you can just rewind to look for these information for the history and physical. We also have the diagnostic test results for echo, sleep study, chest x-ray, ECG, and the laboratory test. For the lipid panel, we have some renal labs, hemoglobin A1C, hematocrit, and hemoglobin. All right, so your task is to select 5 complications to complete the statement. All right, so here's the phrase. It says, the nurse recognizes that based on the assessment data and patient history, the patient is currently at risk for complications, including blank, 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 and blank. And here are the word choices. One is osteoarthritis, stroke, chronic kidney disease, peripheral neuropathy, pulmonary hypertension, cardiovascular disease, depression, obstructive sleep apnea exacerbation, non-alcoholic fatty liver disease, and prostate cancer. You can pause here so you can finalize your answer and you can resume the video. So one of the possible complications that can arise from the patient's medical history is this: cardiovascular disease. This patient is a textbook case for cardiovascular risk because of the BMI of 49.2. That is morbid obesity, which can put more strain and it can cause more stress to the heart over time. And of course, the hypertension. The initial reading was 180 over 94. So that fits into the hypertensive range. And the patient's HDL is too low and the LDL is way too high. So this lipid profile increases plaque buildup. And you add to that the A1C of 8.4%. And going back into the echocardiogram showing mild left ventricular hypertrophy, the patient is clearly at risk for coronary artery disease or even heart failure. And so the bottom line, all these signs point to elevated risk of heart-related complications. Another complication is depression. So when a patient is dealing with multiple chronic illnesses like diabetes, obesity, sleep apnea, psychological stress is very common. And go back into the information, the patient has mentioned feeling frustrated and tired, which could be more than just physical exhaustion. It may signal depression. And let's not forget, depression can interfere with the motivation to manage chronic illness and stick to treatment plans. So yes, this patient is definitely at risk for depression. Another complication is this: obstructive sleep apnea exacerbation. Even though the patient is already diagnosed, he has severe obstructive sleep apnea and is experiencing daytime sleepiness, which suggests that their current treatment is not working well, or they might not be compliant with a CPAP therapy, even though he reported that he wears the mask every night. But that doesn't mean that he wears the mask all night long while he sleeps. So that's something that you need to investigate. And so with the obesity, poor control, obstructive sleep apnea can worsen and lead to hypoxia, arrhythmias, and even cardiac complications. So this is one clear risk that needs attention right now. Another is osteoarthritis, because the patient complains of knee pain, and with a BMI nearing 50, that's not surprising. And so if they're carrying that much weight onto their knee joints, that's going to put extreme pressure onto those joints. It can lead to cartilage wear and tear, and this can also limit their mobility, which can worsen other conditions like diabetes, depression. So yes, osteoarthritis is a concern here. Now, last but not the least, we have stroke. This is a very big one because the patient has uncontrolled hypertension, there is diabetes, and obstructive sleep apnea, and these are the 3 major stroke risk factors. So we are looking at both ischemic stroke from vascular disease or possibly hemorrhagic stroke from the elevated blood pressure. Those cerebral arteries can potentially rupture. and the elevated cholesterol, it's clear stroke is a very real possibility. So this needs immediate risk reduction strategies. Now let's talk about the incorrect options here, including non-alcoholic fatty liver disease. Even though it's true that obese and diabetic patients are at higher risk for fatty liver, we don't have any lab evidence here. There are no liver function tests, no imaging results, and without that, it's only speculation. It's not a current risk we can act on. Another is prostate cancer. We are not going to select this because there's no mention of urinary symptoms, no elevation of the PSA, no family history, or any red flags for prostate issue. So at this point, there's no clinical reason to flag this as a current concern. And if you selected by mistake chronic kidney disease, well, the patient's BUN and creatinine levels are within normal limits. There is no proteinuria mentioned. Yes, we know that diabetes and hypertension can lead to chronic kidney disease, but we're not seeing signs yet. So this is not an immediate concern based on today's information. Another is peripheral neuropathy. This is something that you will often see in patients with long-standing, poorly controlled diabetes. But here, there is no report of numbness, no report of tingling sensation or burning pain. So not enough evidence to include it as a current risk. And for pulmonary hypertension, this could be linked to obstructive sleep apnea, but it has not been diagnosed or even suggested in the workup. And there's no echocardiogram data showing elevated pulmonary artery pressure, and there are no clinical signs of exertional dyspnea or cyanosis. So this is kind of too speculative to list as a current complication. All right, feel free to pause this video and reflect on your answers and resume the video when you're ready for test item number 3.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
It says here, post-operative day 1, which is 6 months later. The patient undergoes a Roux-en-Y gastric bypass and is admitted to the bariatric surgery unit at 7 a.m. on post-op day 1. He has a clear abdominal dressing, a PICC line with IV 0.9% normal saline at 100 mL per hour, and is NPO except for sips of water. He reports nausea and pain rated 5 out of 10. Let's look into the prognosis notes here at 7 a.m. It says patient alert oriented ×3, reports nausea and pains 5 out of 10, incision dry, intact, tolerating 15 mL water every 15 minutes, administered ondansetron 4 milligrams IV as needed and morphine 2 milligrams IV as needed, ambulated with assistance. At 12 noon, blood pressure is 124/76, heart rate 88, respirations 14, temperature 99.2 degrees Fahrenheit, saturation 95%, pain level 3 out of 10, nausea improved, water increased to 30 mL every 30 minutes, incision unchanged, incentive spirometry every 1 hour. All right. On post-op day 3 at 9 a.m., the patient reports severe abdominal pain at 8 out of 10. Nausea and chills. The incision shows serous sanguineous drainage, and the abdomen is tender and distended. Urine output is reduced to 15 mL per hour. So here's the progress note for that day. Patient reports abdominal pain, 8 out of 10, nausea, chills, incision with serous sanguineous drainage, abdomen tender, distended, vital signs, blood pressure 108/68, heart rate 110 beats per minute, respirations 22 per minute, temperature 101.2 degrees Fahrenheit or 38.4 degrees Celsius, saturation of O2 93%, urine output 15 mL per hour, notified provider, administered morphine 4 milligrams IV PRN, awaiting orders. Your task right now is to select all priority complications to monitor. Priority complications. That's your clue. Now, here are the options. One is chronic anemia, wound infection, gastric balloon rupture, anastomosis leak, dehydration, electrolyte imbalances, dumping syndrome, pulmonary embolism. Go ahead and pause the video and resume when you're ready to hear for the rationals. All right, let me start. One of the correct answers here is anastomosis leak. Why is this a big deal? Well, it's because after a Roux-en-Y gastric bypass, this is the most serious things that we need to watch out. Wherein the connection between the new stomach pouch and the small intestine breaks down. So this doesn't happen often, only about 1 to 5% of patients. But when it does, it's a surgical emergency. So if you're talking or if you are considering anastomosis leak, think about the spillage of those contents in the stomach and the bowel spilling into the peritoneal space. And remember that your patient is complaining about a pain level of 8 out of 10. He has a fever of 101.2 degrees Fahrenheit, complaining of nausea, chills, and there's also serous sanguineous drainage at the incision site. So all of these are red flags for peritonitis or intra-abdominal infection. And go back into the progress notes where it says abdomen tender distended, right? That is another classic clue. And the CT scan on day 7 confirmed the leak, which is actually in the future test question. So, but we'll hang tight here. So you as a nurse, in this case, you have to keep an eye on the pain level. You got to monitor for any changes in the drainage or the temperature, and you have to act quickly if things worsen. So here you need to alert the care provider. You have to help with stat CT scan if that's ordered, and you got to prepare the patient for that diagnostic test if it's ordered. So the next one here is dehydration, because this is very common after a bariatric surgery. Patients are NPO, of course, for quite a long time, or maybe they have limited intake early after the procedure, and complications like the leaks can worsen fluid loss. We don't know how much fluid this patient is losing in their gut. And so you got to look for the vital signs and also the urine output of 15 mL per hour when it should be at least 30 mL per hour. And looking into the blood pressure, it's trending down, 108/68. Still within the normal range, but it's going down. That's something that you need to keep an eye on. And the heart rate going up, 110, that's already tachycardia. So that's a classic sign of a low circulating volume. Now, your game plan right now is to monitor their fluid status closely. You have to monitor the urine output closely. You monitor their mucous membranes, if there's any orthostatic changes, or if there's an order for you to administer IV fluids, go right ahead and do that, okay? And If there is no improvement in their urine output after you hydrated the patient through IV, and if it doesn't improve, go right ahead, inform the care provider. We are going to avoid organ hypoperfusion and organ failure here. We don't want acute kidney injury in this patient. Another is electrolyte imbalances. Well, this is something that can accompany with a dehydration. There's going to be fluid shifting because of, another is limited intake, and the surgical stress can throw the potassium and sodium and others out of whack. And so we don't have labs here, but the signs that we are seeing in this patient, there's tachycardia, hypotension, low urine output, suggest volume depletion, which means it could be a low potassium or it could be a low sodium. So these can cause heart issues, maybe mental issues as well. Now, another thing that you should select is this one, pulmonary embolism. Why is that? Well, after bariatric surgery, this can possibly occur most of the time. Even though if there is no report of chest pain, but with PE, it's not always present, especially in this post-op patient. Now, since I mentioned about chest pain and PE, here's the thing. If the embolus lodges into the distal pulmonary artery near the pleura, it may cause pleuritic chest pain due to the inflammation or infarction of adjacent lung tissue. So these are smaller clots, can cause localized symptoms. However, when a PE blocks a segmental artery, the affected area may become ischemic, especially if there's inadequate collateral circulation. And then the dying tissue can irritate the pleura, and that's why a patient may also complain a sharp chest pain. And so going back into the medical history here, the obesity, reduced mobility, the surgical stress can put the patient at a higher risk for developing pulmonary embolism, the sluggishness in their circulation. And looking back into the vital signs, the heart rate that is already elevated, their respiratory rate of 22, and their oxygen saturation of 93% from 95%. And considering that this patient has a history of sleep apnea, it can also affect oxygenation. So it's very possible that the patient is possibly gradually having manifestations of pulmonary embolism. So your task here as an RN is to monitor their respiratory rate, their oxygenation level, and you are going to apply O2 here to improve the oxygenation, and you report those changes to the healthcare provider right away. All right. Now, another complication that you should anticipate is wound infection. The surgical site infections are common post-op, especially in patients with higher BMI. And the signs that we are seeing in this patient, he had serosanguinous or purulent drainage. He has fever going on. There's localized tenderness. The fever alone is a red flag. There's that tenderness in the abdomen. There also that drainage coming from the incision site. So this all point to a possible infection. And you have to really watch for the deterioration here, especially that it can possibly go, it can cause the patient to go into sepsis. Now let's talk about the incorrect options here, such as dumping syndrome. Why are we not selecting dumping syndrome? Remember that this is only going to happen as a complication, only going to happen later when the patient starts eating sugary or high carbohydrate foods. But right now, your patient is still NPO, slightly NPO. They're allowed to take little sips of water. But dumping syndrome is not the complication that you should anticipate here. When you anticipate dumping syndrome, you are going to encounter the patient having nausea, cramping, diarrhea, but not fever, not drainage or abdominal tenderness. And so the symptoms in this case point much more toward a leak in the anastomosis, or it could be the abdominal incision post-surgically. So you don't need to prioritize dumping syndrome until they start eating solid or high sugar foods. So this one doesn't fit here. Now, how about chronic anemia? This is not priority here as well, because our patient's hemoglobin recently is 11.5, which is common, especially in those with obesity or nutritional deficits. But nothing in the post-op data suggests it's gotten worse. There's no bleeding, no fatigue, no hemoglobin drop noted. And the anemia typically causes things like pallor, there's weakness, not fever, abdominal pain, or low urine output. So that's not what's going on here. All right, let's talk about gastric balloon rupture. You can eliminate this one right away because this one is irrelevant. Our patient had the Roux-en-Y gastric bypass, which does not involve a gastric balloon. And balloons are only used for a different procedure altogether. So this is not something that you're going to worry about this patient. So do not get tripped up by this distractor. All right, let's proceed to our next test item.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Number 4. It says, on post-operative day 3 at 9 a.m., the patient reports severe abdominal pain, 8 out of 10, nausea and chills. The incision shows serous sanguineous drainage and the abdomen is tender and distended. Urine output is reduced to 15 mL per hour. I believe that we already scanned this record, and so feel free if you want to scan this one more time. Now let's go into the new healthcare provider orders. One is STAT abdominal CAT scan, IV ceftriaxone 1 gram daily, increase IV saline to 150 mL per hour, NPO maintain PICC line. Monitor urine output and vital signs every 2 hours. Continue low-dose heparin 5,000 units subcutaneously every 12 hours. Blood cultures ×2. Your task, it says, on post-operative day, the nurse develops a plan to address the patient's suspected anastomosis leak. Drag nursing actions to the relevant nursing actions column if they should be included. So here's that column, and these are the nursing actions. So one of those is encourage deep breathing exercises, apply oxygen 2 liters per minute via nasal cannula, administer insulin per sliding scale, monitor vital signs every 2 hours, offer clear liquids 30 mL every 30 minutes, prepare for possible surgical intervention, administer IV fluids at 50 mL per hour, and notify the provider. Pause here if you need to, but let me get started with the rationales. So one of those nursing actions should be this: notify the provider immediately, because when you suspect an anastomotic leak, time is very critical. The patient is showing red flags. There's severe abdominal pain, 8 out of 10, fever, abdominal distension, and drainage. These strongly suggest that the patient is probably having peritonitis, right? It can lead to sepsis. So you need to escalate the care immediately by notifying the provider. So this is going to set the stage for urgent diagnostic workups like the CAT scan that the medical provider ordered, of course, with contrast. Or possibly this patient will need immediate transfer to the OR to fix the leak. All right. Another intervention that you should select is this one: prepare for possible surgical intervention, which I just said. So an anastomotic leak doesn't always require surgery right away, but if the patient deteriorates or if conservative measures are failing, then surgical repair becomes very necessary. And you, as a nurse in this case, you should anticipate that direction and you should prepare this patient accordingly for immediate surgery. So you have to include ensuring that the patient has good IV access. So it will be used for giving those medications necessary, or possibly rapid bolus if this blood pressure can drop. You also need to prepare for making sure that the consent forms are being signed, ready if needed, and that pre-op protocols are followed quickly if the surgical team decides to intervene. So you as a nurse here, your preparation really can save time and possibly save this patient's life. Another nursing action that you should select is monitor vital signs every 2 hours. This is not just routine monitoring, this is vigilant surveillance. Because with the patient's blood pressure trending lower, the 108/68 and the heart rate going up, you are seeing signs of early hemodynamic instability, which could mean infection or volume loss from the leak. So checking the patient's vital signs frequently can help you detect those trends toward hypotension, tachycardia, and fever, or even respiratory distress. So this is the kind of close monitoring that will help the team decide whether the patient will require boluses of IVs or maybe to get this patient transferred for ICU care or to take other interventions. So you got to anticipate very fast. Another intervention here is apply O2, 2 liters per minute via nasal cannula. Although our patient's saturation is borderline at 93%, this patient has a history of obstructive sleep apnea, and possibly he's developing atelectasis from shallow breathing due to the pain. There's an abdominal incision. And when you're administering O2, this can help maintain adequate saturation. It will improve tissue perfusion, especially if the patient becomes septic, which can compromise oxygen delivery. So this 2 liters of O2 is a very proactive step that you can do to reduce the risk of hypoxia. All right. Let's talk about the last one. Encourage deep breathing exercises. This is very important, especially abdominal surgery patients. They are at a higher risk to developing atelectasis and pneumonia, particularly if they're in pain and if they're not breathing deeply. So you need to encourage incentive spirometry use and make sure that they do deep breathing every hour. Not only promotes lung expansion, but this can also help prevent pulmonary complication. This is a very simple task that you can encourage the patient to do, but it can lead to huge impact in their recovery. Now let's talk about the incorrect options, such as administer IV fluids at 30 mL per hour. Well, this is too slow or too low of a rate, especially for someone who has early signs of hypovolemia. And go back into the patient's data. The urine output is only 15 mL per hour. That is oliguria. And looking into the patient's high blood pressure of 108/68, that is trending down. So also pay attention to the order from the medical provider. Remember that the order is to increase IV saline to 150 mL per hour. So we are not picking this IV fluid of 50 mL per hour. All right. Now, what about this one? Offer clear liquids 30 mL every 30 minutes. Absolutely not appropriate, because when there is a suspicion of anastomotic leak, The patient should be made NPO right away to avoid worsening the leak, to allow, it will prevent the seeping of the gastrointestinal contents into the abdominal cavity, which can worsen the peritonitis. So keep the patient NPO right now. If you selected administer insulin per sliding scale, well, there's no data provided that will tell us that the patient needs insulin, right? No. So if there is no indication, this one isn't safe. It can cause hypoglycemia, especially that the patient is still not eating. In acute cases like this, we treat what's in front of us. We have the hemodynamic changes, the infection, the respiratory status, but we're not going to treat those unrelated protocols unless they are clearly ordered. So no insulin for now. All right, let's head into our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Number 5. It says post-operative day 7 discharge preparation. By post-operative day 7, a CAT scan confirmed a small anastomosis leak, managed successfully with antibiotics, NPO status, and increased IV fluids. The patient is stable, tolerating a full liquid diet, and ambulating independently. Well, that's good. He expresses anxiety about dietary compliance and weight loss expectations at home. So here's the clinical data. Vital signs of blood pressure 128/80, heart rate 82, respirations 14, temperature 98.6, saturation of 97%. The incision site, it's healing with minimal drainage. And we have information about the patient's discharge plan to be on full liquid, which is high in protein, low carbohydrate for 2 weeks, transitioning to puree diet per dietitian. Daily multivitamin, calcium, parenteral, cobalamin, and iron supplements. Follow up with bariatric surgeon, dietitian, and sleep specialist in 1 week, and to educate patient on avoiding straws, eating slowly and stopping when full, maintaining skin fold hygiene, and adhering to CPAP therapy. So here, your task is, for each nursing action, select whether it is indicated, contraindicated, or non-essential. Here's the matrix. You can pause here before you are going to answer the question. But let me proceed. We have the first nursing action saying, instruct to transition to solid foods in 1 week. Obviously, that is contraindicated, because even though it might seem like a week is enough time to move from the full liquids, but it's not safe after a patient has a Roux-en-Y. Remember that the new stomach pouch and the fresh surgical connections, the anastomosis, those need time to heal. And if you are going to introduce solids too early, this can increase the risk of mechanical stress, which could cause the surgical site to leak or even rupture. Plus, solids too soon can also trigger dumping syndrome, wherein the food can move too quickly into the small intestine. The patient can end up with nausea, diarrhea, dizziness, and low blood sugar. And so, you as a nurse here, you should stick to the full liquid diet as part of your education. Make sure that you emphasize that to the patient for at least 2 weeks, then gradually progress per the surgeon's orders. Now let's talk about the next one. Teach to avoid high carbohydrate foods. Of course, that's indicated. This is very important advice, especially that the patient who has an elevated A1C pre-op, and it suggests that they have poorly controlled diabetes. And after the bariatric surgery, those high carbohydrate foods can trigger dumping syndrome. It can spike their blood sugars, and it works against their weight loss goals. And so we are going to implement high protein, low carb diet, and that should be the primary recommendation after the surgery to promote their healing. It will stabilize their blood sugar, and it will help prevent rapid gastric emptying. So this teaching is not optional. This is a vital part of preventing the complication. Let's talk about instruct to keep skin folds clean and dry. Of course, this is indicated because patients who are post-op, and they often have deep skin folds, and you know that these can trap the moisture. This can lead to fungal infections like candidiasis. That's very bad news in any patient, but even more so when they're healing from major abdominal surgery. So you got to make sure that they keep their skin folds clean and dry to help protect from the surgical incision. It will also reduce overall infection risk, and it will improve comfort and hygiene. So this is a very basic, essential nursing, but it can really save someone's life. Now let's talk about administer oral cobalamin daily. Pay attention to the route, oral cobalamin daily. That's contraindicated. This is a crucial pharmacology testing for you because the Roux-en-Y procedure bypasses part of the stomach and the small intestine where the vitamin B12 is normally absorbed. So even if you give oral cobalamin, the body cannot absorb it properly without the intrinsic factor from the stomach. Instead, the patient will get more benefit from the parenteral B12. So I believe it was already mentioned that he is getting it. He's getting it monthly. So that's the standard of care to prevent megaloblastic anemia, especially since the patient already has low normal hemoglobin level of 11.5, right? Low normal, I should say. It's not that severe yet, but it's going down. Now, let's talk about the next intervention. Encourage use of straws for fluid intake. What do you think about this one? Well, the answer to that is contraindicated because even though if you think that straw use is harmless, but after gastric bypass, it actually introduces air into the small stomach pouch. And this air can cause painful distension. It can cause bloating. And in worst cases, it may increase the pressure on the anastomosis. So this will raise the risk of a leak. And that is why discharge instructions specifically tell the patient to avoid using straw. So go back into the discharge plan where it says that, avoiding straw, all right? It is a very small detail, but it has a huge impact. No straws post-op because this can cause gas buildup and pressure into the healing stomach. So no straw. Lastly, we have scheduled a sleep study in 3 months. This is indicated because the patient has a history of obstructive sleep apnea before surgery, and their sleep study of 30 AHI is already considered moderate to severe. And so weight loss from the bypass often improves or resolves obstructive sleep apnea, but we cannot assume it's gone. And so When we schedule a repeat sleep study in about 3 months, this is the right move to reassess the severity and to determine whether the patient still needs CPAP therapy. And also this aligns with the standard follow-up care from sleep specialists. So here, do not drop the ball on obstructive sleep apnea management. You make sure that they will follow through to ensure safe recovery. And so the rest of the answers here. Incorrect actions. These are not safe, right? So go back into the contraindicated, instruct to transition to solid foods in 1 week. We have administer oral cobalamin daily, encourage use of straws for fluid intake. So these contraindicated acts are harmful. This can cause ineffective treatment. And in the context of a Roux-en-Y care, even small missteps can lead to serious complications. They're not optional. They're incorrect because these contradict evidence-based practices and the specific needs of the client. So imagine that if you're going to transition the diet to solid foods in 1 week, that is a huge violation to the provider's order. Again, offering solid foods too early can cause leaking and dumping. And if you are encouraging the use of straw, it can increase the gas and it risks surgical site pressure. And giving oral vitamin B12 is ineffective post-bypass surgery. And so if you are also going to ignore skin fold hygiene, that invites infections, or if they skip follow-up for the obstructive sleep apnea, this may delay withdrawal from the CPAP, or they might miss residual breathing problems, or you might miss the breathing problems the patient may have. So keep these in mind. Let's have our next test item.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
This is a bow tie. It says, on post-operative day 7, the nurse evaluates interventions for anastomosis leak and discharge readiness. We got information about the vital signs: 128/80, blood pressure, heart rate 82, respirations 14, temperature 98.6 degrees Fahrenheit, oxygen saturation 97%. And I believe we already scanned this, so feel free to reread this one more time. But let's work onto the task here. It says, select the target outcome, parameters to monitor, and actions to take for ineffective outcomes. So pay attention to the boxes right there. And here are the options. The target outcomes options are the following. Patient resumes full pre-op activity levels by discharge. Patient discontinues all meds upon discharge. Patient is pain-free with no dietary restrictions by discharge. Patient achieves 10% weight loss by post-operative day 7. Patient is stable for discharge with resolved anastomosis leak and readiness for home care. What do you think would be the best target outcome? The answer to this is patient is stable for discharge with resolved anastomosis leak and readiness for home care. because by post-operative day 7, the patient is meeting essential discharge criteria. Their vital signs are all within normal limits. The blood pressure, the heart rate, the temperature, their oxygen saturation at 97%. And the surgical incision is healing well with only minimal discharge, which tells us that the previously identified anastomotic leak has resolved. And this leak was appropriately managed with the antibiotics by keeping the patient NPO and adjusting their fluid intake. And the fact that the patient can now tolerate a full liquid diet and is walking independently indicates that they're physically stable and functionally ready for discharge. So this aligns perfectly with what we aim for in the post-op recovery and safe transition to home care. So as a nurse here, you should assess and confirm these outcomes to help you ensure that the patient can safely continue their recovery outside of the hospital without facing any recurrence of the complications. Okay. All right, let's look into the parameters to monitor, and the options are waist circumference reduced by 2 inches, tolerating solid foods without discomfort, patient ambulates 1 mile daily, blood glucose consistently less than 100 milligrams per deciliter, and incision healing with minimal drainage and vital signs stable. What do you think would be the parameters to monitor here? Well, one of the correct answers is vital signs stable. Of course, you want that, right? Whenever there's that stable vital signs, it indicates that the early signs of infection, like a fever on day 3, have resolved. And these also reflect good cardiovascular and respiratory status. And so if the vital signs have been unstable, that would really raise concern for persistent infection or ongoing drainage. The other answer is incision healing with minimal drainage, because a healing incision that's only draining a small amount is strong sign that the surgical site is recovering well, compared to the earlier serous sanguineous drainage noted on day 3. So this one is a huge improvement. And if the drainage were to continue, or if the wound appeared red, or if it appeared inflamed, that would signal a problem like an infection or a fistula occurring. Now, let's talk about the incorrect options here. If you selected blood glucose consistently less than 100 milligrams per deciliter, even though we know that normal glucose is generally good, aiming for that under 100 milligrams is right. This is somewhat impractical because the stress response and fasting state can cause fluctuation. So this is not a reliable indicator of leak resolution. Now, if you selected patient ambulates 1 mile daily, well, that's kind of way too much physical activity just 1 week after surgery. And if you're going to push the patient to walk this far, this can strain the healing surgical site. So we are going to encourage the patient to do gentle, independent walking. That is more appropriate. Now, if you selected tolerating solid foods without discomfort, well, introducing solid foods too early increases the risk of damaging the surgical site or the anastomosis. It can trigger complications like leak or dumping syndrome. So a liquid diet is still needed during the early stages of healing. Now, if you selected waist circumference reduced by 2 inches, well, this kind of physical change takes time and is not expected in just 1 week. Because there's going to be a possible fluid retention, there's going to be swelling, there's going to be healing delay, and so this is not going to be a reliable indicator. So disregard that. So let's talk about the options for actions to take if the outcomes are ineffective. The options are advanced diet to pureed foods, order immediate surgical re-exploration, encourage immediate return to full activity, administer insulin per preoperative regimen, obtain wound culture and collaborate with the provider for antibiotic management, and notify provider and reassess fluid status. Now, let's fill the boxes here. One of the correct answers is notify provider and reassess fluid status. So if the patient has unstable vitals like low BP or let's say rapid heart rate, or if the incision is still draining, it may mean that the leak has not resolved or that dehydration is a concern here. And if that happens, then the nurse should call the provider for further evaluation and to make sure to check the patient's fluid status. All right. Now, the other answer is obtain wound culture and collaborate with the provider for antibiotic management. This is very important. Now, if the incision continues to drain or if the patient develops a fever, it could mean there is an infection going on. And so getting a wound culture from the wound area or the incision can help us identify the causative microorganism, and working with a care provider or the healthcare provider ensures that we are treating the patient with the correct antibiotic for that particular organism, right? So let's talk about the incorrect options here. If you selected administer insulin per pre-operative regimen, the clue here, pre-operative regimen, this is very risky because the patient's insulin needs have likely changed due to surgery. There's already fasting that has happened and the stress response. So if you're going to continue the same plan, same dose of the insulin before the procedure without reassessing, could lead to either hypoglycemia or maybe hyperglycemia. So what we should do here instead is to follow the current orders, make sure that we are administering the prescribed medication, which is the insulin glargine 12 units at nighttime. All right, the other one is encourage immediate return to full activity, which is also incorrect because this could harm the surgical site. And we know that strenuous activity might cause the anastomosis to rupture or slow healing. So we want to ensure that there is gradual return to light activity, which is safer. Now we have order immediate surgical re-exploration. Of course, that's quite obvious, right? This is not within your scope of practice. And reoperation is a last resort. And here the patient is stable on day 7. So we are going to implement conservative management that is working for the patient. So here it's too early to jump to surgery without clear signs of failure. Again, this is not under scope of practice as an RN. If you selected advanced diet to pureed foods, well, if you are allowing this patient to transition to solid foods, pureed foods rather, this could reopen the leak or it could cause dumping syndrome. So we have to maintain that full liquid diet, which is prescribed to keep the surgical site protected. All right. So this time we're going to recap what you've learned from this case study. So for the test item number 1, that was a hotspot test item. You have identified those findings in bariatric surgery candidates that require immediate action. I'm not going to repeat all those one more time because those are plenty. For test item number 2, you answered the closed type question. And in that test item, you recognize the patient's risk profile for obesity-related complications. So thinking about the stroke, the cardiovascular disease, the exacerbation of obstructive sleep apnea, osteoarthritis, and depression. So these require targeted interventions like blood pressure control, CPAP compliance, and mental health support. On test item number 3, you answered a extended multiple response, and in here you monitored for the critical post-op complications on day 3. For test item number 4, that was a drag and drop. In here, you developed a targeted plan for suspected anastomosis leak. So you included notifying the provider, preparing the patient for surgery, monitoring the vital signs every 2 hours, application of oxygen 2 liters per minute, breathing exercises. On test item number 5, that was matrix multiple choice. This was that test that you ensured discharge instructions aligned with the bariatric surgery recovery needs. And for test item number 6, that was a bow tie evaluating outcomes. And in that, you made sure to confirm anastomosis leak has resolved and making sure that the patient is ready for discharge. All right, so if you find this session helpful, and if you learned something from this learning content, do not forget to subscribe to the channel and make sure that you click all the buttons, share it with your friends who are preparing for the NCLEX. And I thank you for your time, and I'll see you again in our next review.